Good afternoon, everyone. Welcome, welcome, welcome. We're so glad that you're here. Whether you're joining us here in person at the Weil Center for Integrative Medicine or tuning in virtually, we're glad that you could join us today. I'm Dr. Stephen Dahmer. I'm the director of the Weil Center for Integrative Medicine and also a very proud graduate of our fellowship in 2006, the largest and longest standing integrative medicine fellowship in the world. We had a great morning. It started out in Sabino Canyon. Nice day for a director. While we were walking a bit, I was just thinking of a couple words to welcome all of you here today. And I remembered when I stepped into the role as director here, our old center used to be the Mabel home about 2 blocks away. There was a beautiful, very tiny library that I spent many hours in. And one of the books I stumbled across was Dr. Weil's book, Health and Healing, Understanding Conventional and Alternative Medicine. It was published in 1983. In that book, Dr. Weil first proposed what he called a National Institute on Health and Healing. Closely aligned with his blueprint for integrative medicine, but Rebel thought at the time that we would focus on health and healing. Reading that triggered a bit of an obsession for me that I would go to our conferences and I would look after the NCCIH researchers to ask them about if there's ever plans for an NIHH, a National Institute of Health and Healing. And through our own amazing Dr. Esther Sternberg, first got introduced to the ideas of Dr. Langevin, who will be giving our lecture today. And it culminated in an NCCIH coalition meeting in Bethesda, Maryland, where I first heard Dr. Langevin speak. And for the first time in my career, after nearly 20 years in integrative medicine, at a prominent national organization, I heard words like resilience, health, vitality, homeostasis. And this really resonated with me because this has really been a core tenet of integrative medicine that we're not afraid to speak and harness innate healing capacities. And I think it truly sets integrative medicine out as a differentiator. And was so excited to see on a national level discussions of this. And today you're in for an extraordinary treat filled with insights. Hopefully will inspire each and every one, advance our mission together. And before we get to that, it's my distinct pleasure to introduce another colleague that understands healing-oriented medicine extremely well, our provost, Patricia Prelock. Patty Prelock is the provost and chief academic officer at the University of Arizona. She joined the University of Arizona on May 19th of this year after serving as interim president of the University of Vermont over the past year. And I'll say it's been such an honor to be a center of excellence that is within a larger organization like the University of Arizona. And Dr. Prelock is a highly accomplished leader, scientist, scholar, clinical speech language pathologist. She's an internationally recognized expert in nature and treatment of autism in children, interprofessional education, and collaborative practice, as well as family-centered care. And with that, Provost Prelock.
Thank you so much, Stephen. It's great to be here. And I don't know if you remember, but I was 3 days on the job, and where was my first stop? It was the Weil Center for Integrative Health, because I have a dear place in my heart. And at the University of Vermont, I had the opportunity to bring the Osher Center for Integrative Health there and have lots of friends there. And I'll tell you a little story about Helene in just a moment. But it's my distinct privilege to be asked to introduce this afternoon's speaker, Dr. Helene Langevin. And Dr. Langevin, as you know, recently retired as director of the National Center for Complementary and Integrative Health at NIH. Since 2018, she has been the architect of whole person health at the federal level, truly transforming how NIH addresses chronic disease in America. She also co-led the NIH HEAL initiative, chairing the Interagency Pain Research Coordinating Committee, and launching the Whole Person Reference Physiome, funded by 20 NIH institutes. I think she was one of the first NIH Institute directors that I know that actually got them to work together. And Dr. Langevin trained in internal medicine and endocrinology and metabolism at Johns Hopkins and is a fellow of the American College of Physicians. And before joining NIH, she directed the Osher Center for Integrative Medicine at Brigham and Women's Hospital and Harvard Medical School. Now, the good news for us is that, or for me in my previous life, is Dr. Langevin is now returning to the University of Vermont, where she belongs, where her academic career began, to build a research program for our UVM Osher Center and serve an advisory role at the Academic Consortium for Integrative Medicine and Health. So I have a very special place in my heart for Helene, as she is the person who actually motivated me to help advance our integrative health program at the University of Vermont. And she walked into my office when I was Dean of the College of Nursing and Health Sciences. I think it was in 2012. And she said, "Patty, I need to talk to you about how we need to advance this program that was in the College of Medicine to something bigger, because we have something special here." And after that, I was convinced that it belonged in the College of Nursing and Health Sciences, and I would create this collaboration across all our health professions, including our colleagues in the College of Medicine. She really was the impetus for me to move forward and to say, we are going to bring our community together. We are going to bring our medicine colleagues together, and we're going to bring all the other health professionals who care about integrative health and whole person health and make a difference. And we brought nutrition in, and social work, and speech pathology, and physical therapy, and occupational therapy, in addition to our physician colleagues and our nursing colleagues. And what happened was we created an Osher Center for Integrative Health. We were the last of 10 in the U.S., and there's one in Sweden. So there's 11 Osher centers that have allowed us to really develop research and practice and service to our community in Vermont. And so when I came to Arizona, I was devastated to leave my colleagues there, but I said, collaboration, this is a possibility. And when I met Stephen and Esther and everyone else, I said, we will make this health and well-being a perspective for the University of Arizona as well, although the Andrew Weil Center has been here for many, many years, and many of our Vermont people were trained here. You have done something special, and I want to make sure that the university raises up the Andrew Weil Center, because this is something quite powerful and really is something that we need to continue to do. So today, we are fortunate to have Helene give us her time to answer the question we all need answered: whole health, where do we go from here? She will share insights from her NIH tenure on the research, evidence, and policy frameworks needed to move whole health from a concept to true practice. So please join me in welcoming my dear friend and wonderful colleague, Dr. Helene Langevin.
Thank you so much, Patty. And I want to first begin by telling all of you how incredibly fortunate for you all to have Dr. Prelock here. After everything that she did at the University of Vermont, really transformed this sort of fledgling sort of integrative medicine program that we dreamed of together so many years ago into this just amazing program that I am now very fortunate to be able to rejoin. So many circles sort of circling around each other, and I think that the sort of future collaborations, across the Osher Collaborative also with the Andrew Weil Center, I think that the sky is the limit here. And with the support that you're obviously going to get from Provost Prelock, you couldn't be in a better place. So I'm just very excited for you all. So, and also very excited to be here. This is my first time in Tucson and first time at the center, and very, very fortunate that, as we say, Stephen said, we started the day with a wonderful walk. I get to really see the splendor of the nature here, and to meet already many of you and understand more about what you all do here, which is just really it was just a delight to speak to already so many of you today. So I've taken the liberty of inserting the word person in my title here, as you see, but I want to really, hopefully, the message that I want to convey to all is there is a place to go from here, and it's actually a really exciting place. So I want to first basically show you just an example this is just an example of all of the conferences where I was in the past 2 years or so, where I was invited as a speaker, where the theme, not only the theme of my talk was on whole person health, but the theme of the entire conference was either on whole health or whole person health. And there's more. I mean, we just put a few here, but you can see how this is a concept that has really taken a lot of different groups by storm, in a sense. There's a lot going on. Another way to think about this is just a list of PubMed hits you can see that over the last 5 years or so, if you search for either whole person health or whole health, there's an explosion of publications, in this area. So a lot of interest here. So, okay, so what is this? What does it mean? And I think that I'm not going to call it's not a clash of terms. I would call it a plurality of terms that's centered on the word health, right? So you have integrative health, you have whole health, and whole person health. But importantly, they're all about health, okay? So this is what they all have in common, right? These terms. But what about differences between them? And so I've taken the liberty here of listing a few sort of characteristics of these different aspects of forms of health. And one, so integrative health, right? What characterizes integrative health? Well, first, the way it happened is by bringing together different kinds of therapies and practitioners, for example, of different types of providers that bring in different perspectives, right, of complementary therapies and conventional therapies together. So there's kind of an integration of different kinds of practice. And so I would say that's one of the, not the only characteristic, but it's one of the characteristics of integrative health. What about whole health? Well, whole health is a vision, right, for that extends beyond, certainly beyond the person, certainly beyond healthcare. It's almost a vision for society. It's a transformational vision that has been championed very notably by the Veterans Administration, but that has been kind of taken on by many, many different organizations that really sees the need for a few things. First of all, focus on the various different components of well-being, right, of the person. So physical, mental, emotional, and but also going beyond that, socioeconomic, right, well-being. It's a wide concept. It involves transformation of how we approach caring for people in many, many different ways. And another aspect that's important in whole health is really focusing on the patient, on the person, what matters to the person. And the VA has articulated this very, very well in their sort of their descriptions of the practice of whole health and how their healthcare at the VA has been transformed in that way and is undergoing transformation. What about whole person health? So why is the word person in there? And this is something that I'm going to spend a certain amount of time on because I want people to understand that this is a concept that we're not the only people who come up with this, but certainly at the NIH and NCCIH in particular, we've focused on two aspects of health where research we felt had been lacking. What are these two aspects? One aspect is the lack of integration, meaning that overwhelmingly how we study the body and how the person, and we study the types of aspects of the health as well as disease of the person, we tend to focus on different parts of the person. We focus on different systems of the body, cardiovascular system, musculoskeletal system, digestive system. And not only is the research on these different parts of the person conducted by different people, different groups of people, it's also funded by different institutes at NIH. And the way medicine is practiced, not exclusively, but a lot of it is in a specialized sort of way. We talk about, silos. But there's another aspect, and so research that actually addresses the whole person is rare. Why? Well, in great part because it's not easy to do. And so there's really a need for more of that and understanding how to do it well. The other thing is when I call focus on positive health processes, because overwhelmingly, if you look at the kind of research that we excel at, that we do well, it's overwhelmingly focusing on understanding disease and treating disease. And diseases, as we understand them, typically tend to be sort of segregated, one organ or system at a time. So these two aspects, multi-system and what I call multi-scale integration, meaning that by multi-scale, I mean integrating from, molecules to cells to tissues to organs to whole people to families, communities, and the environment. Integrating across all of these scales, but also across within the person, within all the different physiological systems. So it's kind of integrating two ways. And then the positive health processes. So, okay, why do we need to do this? Well, this is no surprise to you all. I'm sure you've seen this graph before. This is a huge problem that we have right now. Healthcare is really essentially not producing a good return on investment in this country. We're spending so much more on healthcare compared with other developed nations, and we're getting worse outcomes. This is life expectancy, but you can list a lot of other types of outcomes, and you would get a similar picture. So, why? Well, the problem is, as I said earlier, is a compartmentalization of healthcare, such that we focus very much on what goes on the right-hand side of this picture, or diseases, one organ at a time, and one medication for each problem separately, so that by the end of the time somebody reaches the age of 60, 70 years old, many people have what we call co-occurring conditions, right? And these co-occurring conditions are all treated as though they had nothing to do with one another, usually with different drugs, right? And the fact that these co-occurring conditions occur within the same person is somehow not really part of the equation. So, what does whole person health base itself on? Partly is that to recognize that there are factors that are common to many of these conditions: chronic stress, poor sleep, poor diet, sedentary lifestyle. These are we know that these are predisposing factors to many of these chronic diseases that we know now are causing, very much responsible for this increased mortality that we're experiencing, increased morbidity. And so cardiovascular disease, metabolic disease, diabetes, chronic non-alcoholic fatty liver disease, degenerative joint diseases, even depression, all of these diseases typically occur very much can occur within the same individual, but the predisposing factors are all the same. So what can we do about that? Well, if you look at the top of the picture, you see that the arrow from healthy to less healthy to disease has arrows pointing in both directions, meaning that it's not necessarily only going in the red direction, from health to disease, but that there are opportunities to reverse the process, slow it down, but possibly even reverse it, as long as the intervention is done at a soon enough stage. And this reversal of what we call the reversal of pathogenesis, right? What is pathogenesis? Pathogenesis is the generation of disease. What is the reverse of that? And there's a term for it. It's called salutogenesis. And it's these green arrows. It's the arrows that go back in the direction of health. Do we do any research on this? No. very, very little. And this is what we need to do more of. And so how could we approach this research agenda? First of all, understanding how to promote salutogenesis. And it's more than just prevention. It's actually restoring health. And so the hypothesis is that a combination of self-care as well as multi-component intervention addressing the main pillars of so psychological, nutritional, and physical aspects of care that address all of these predisposing factors, not just one at a time. Okay? And so the idea is that this is what we hypothesize might help restore whole person health. But doing research and show that is not easy, right? That's why we haven't done it yet. So I'm going to now focus for the rest of the talk on where we are right now in terms of what are the opportunities that exist at the moment to advance a research agenda in whole person health. And I'm going to specifically talk about what are the opportunities at NIH. So as you know now, even though I'm retired from NIH, but it's my great pleasure to now be able to speak as a former director of NCCIH. And I feel like this is a great privilege for me to be able to talk about things that are happening at NIH, that NIH is difficult for people within NIH to communicate because we've lost a lot of our channels of communication. Hopefully being restored within, a short amount of time. But I think that over the past 6 months, there's been a lot of essentially information blackout, right? Our website has not been able to be updated. I used to write director's messages a couple of times a month. I haven't been able to do that since the past January. So this new position is great for me because it gives me an opportunity to explain things and hopefully help people to understand what's going on. So I want to talk about new research opportunities in both multi-system and multi-scale integration, as well as positive health processes. First of all, why is this important, right? Why is research so important, especially now? So with all of the difficulties inherent in doing research, especially research on whole person health, I think it would be a natural thing, and I've certainly had many conversations with many people who sort of argued, well, why don't we just implement the healthcare changes? It makes sense to do it. Why do we have to spend all this extra time and effort to do research? Well, as we all know, right, you can practice integrative health. The question is, who's going to pay for it? And it's true that in some cases, some healthcare systems are willing to reimburse and pay and implement some changes and integrative health practices, for example. But in general, for example, Medicare, Medicaid, and large insurance coverage payers, they require data. They want to know, is this going to be cost effective? If I'm going to add something to a plan, a healthcare plan, or insurance coverage, what is this going to do to make people healthier? Is this going to be worth the money? And a lot of these data are difficult to produce. But without these data, without insurance, without reimbursement, integrative health will remain something that will be only restricted to people who can afford to pay for it, and we don't want that, right? That's not a good outcome. So we really need research. So another part of why it's important to do research right now is that NIH has undergone some tremendous changes in the last year that has been very confusing to a lot of people. It's been confusing even to people inside NIH, let me tell you. And it would be tempting to conclude that let's just not even bother with, attempting to get funding from NIH. Let's go to other types of funding sources, either nonprofit or charity organizations or philanthropy, etc. that's fine. And I think that that's great to diversify, sources of funding, absolutely 100%. But I would argue that it's very, very important that people don't give up on NIH right now, and I will explain to you why. And the reason why is because there are some unique opportunities happening right now that are right in front of us, and that would be important to see. So I'm going to talk about those opportunities, and also what are the problems that we need to solve in order to take advantage of them. So what are the opportunities? Well, I'm going to start by talking a little bit about the history of whole person health. How did this happen at NIH? How did NIH get interested in whole person health? So way back at the beginning, back in the 1990s, when the first versions of this, was called the National Center for Complementary and Alternative Medicine, right, was created. There was a need that was identified to understand and do research on the types of therapies that were outside of the medical system that people were using on their own and were largely not communicating with their conventional physician. And it was kind of almost this parallel system of healthcare that existed, that was revealed by this seminal paper by Dr. David Eisenberg way back in 1993, I believe, where did a survey and found that 40% of the American public was using these things, and of these 40%, 70% didn't talk to their doctor about it. This really opened people's eyes and to this phenomenon, and their Congress decided that we needed an institute. It wasn't an institute; it became a center. But the budget for the center was obviously not large, and has grown since, but not very much. So it's as you can see, this little appendage to the NIH is not actually drawn to scale, okay? If this was actually drawn to scale, you probably wouldn't even see it. So the next thing that happened is that the NCAM became NCCIH to emphasize the change to integrative health, to show that, and this was when my predecessor, Dr. Josie Briggs, was the director. She really felt, and for very good reasons, that we wanted to focus on complementary therapies, not as alternatives, right, to conventional treatment, but as complements, and also to the integration into conventional healthcare was extremely important. So that, hence the name change. But under Dr. Briggs's leadership, NCCIH did two things that were extremely important. One is it put NCCIH on the map at NIH as a whole with a focus on non-drug interventions. It was really, and the way that they did this was to promote create a program called the Pragmatic Trials Collaboratory. Used to be called the Healthcare Systems Collaboratory. To do what's called pragmatic trials, which means that to study an intervention in the context in which it is delivered. Not in some place somewhere outside, like, in a research lab, for example, where patients are randomized to a treatment versus a placebo, but then you can do these types of work, but then you can find effects, in this kind of research setting, that what we found is that when these interventions are then put into the healthcare setting, they don't work, because the way that the treatment was administered in the context of the research there was not a fidelity to how the treatment is delivered in the real world. So this was a real attempt to tackle the reality of these complex interventions that are not simply like prescribing a pill. It's complicated. Doing research on something like acupuncture or something like yoga is hard. And how do you design a control group for that? What is the best control group for something like acupuncture? And how do you design a study that is both scientifically rigorous but also is consistent with how acupuncture is practiced? So the pragmatic trial methodology that was developed was extremely important. And importantly, this was not just restricted to NCCIH. This permeated all of NIH. It was done in collaboration with the National Institute on Aging, which was a very important partner of NCCIH through that. So the set was staged, right? So when I came to NIH in 2018, I really wanted to go the next step, which was to really try to see whether it would be possible to set up a research program on whole person health that will build upon this foundation. And so this kind of little cartoon that I drew here, I went around NIH for a couple of years and talking to all of the other institutes and really sort of making them aware that this particular schema of whole person health was not just relevant to NCCIH, it was relevant to every single institute at NIH. And believe it or not, people understood that. It was obvious to, for example, the National Institute on Diabetes and Digestive Diseases, that chronic stress, poor sleep, poor diet, they know this, right? It's just that they don't put it together. And separately, they don't tend to fund research grants that would address both the diabetes and, lo and behold, the high blood pressure that the same individual may have in response to the same predisposing factors, right? Or the osteoarthritis that they may have because, stemming from the overweight or the lack of exercise. So you can see how all the themes that are listed on the left, non-drug intervention and pragmatic trial methodology, but also multi-system integration, positive health processes, health restoration, disease prevention, healthy aging, and what I call the learning health system, which is going one step beyond the pragmatic trial, is to do pragmatic trials not only in partnership with the healthcare systems, but also with their collaboration, such that at the end of the study, the results of the study are actually implemented in the healthcare setting. And we've actually done some of that in collaboration with CMS, for example. And it's very important because it makes sure, for example, we funded a study of acupuncture for low back pain in older adults, and they agreed from the start that based on the results of the study, they would actually reimburse acupuncture. Turns out they decided to reimburse it anyway, but still, it was the first time that we had actually done a study like that in partnership with CMS, and they want to do more. So, what's going on now? Well, something happened, and what I'm talking about here on this slide, that's been kind of gradually happening over the past, I would say, 5 years, okay? But this past year, something very dramatic happened, and this was MAHA, okay? All of a sudden, there is a mandate from the Department of Health and Human Services to, and I'm going to read it, okay? The National Institute of Health will launch an initiative on chronic disease to leverage and align existing NIH research projects, improve NIH coordination on chronic disease research, and generate actionable results for diseases arising in childhood and adulthood. And then, the next bullet, the NIH will launch a new whole person health approach to chronic disease prevention research and leverage collective expertise across the agency to catalyze transformative discovery science and interventions strategies that promote wellness, resilience, and optimal health, including metabolic health at all stages of life. This is now the directives that the NIH is getting from the Department of Health and Human Services. This is what the NIH has to do, okay? Because our role is to execute the priorities of the administration. So, this is serious, right? The NIH has to do this. So, what are the implications of this? Well, think about it. The annual budget of NCCIH is $170 million. The annual budget of the NIH is $48 billion. So imagine if 10% of NIH's budget went to whole person health. And that's conservative, okay? Likely that it's going to be much bigger than that. That would be $4.8 billion distributed across NIH, obviously not just NCCIH. This is an all hands on deck effort that is underway right now. So I think that's pretty amazing that this happened so quickly, but it wasn't an accident the fact that we already had, for the 5 years before, assembled this coalition across NIH. We already had projects. We already had working groups. We already had. By the time MAHA came along, we just said, we have your program. It's right here. It already exists, right? So what are the current important opportunities? Number one, there is alignment of NIH around whole person health. Number two, there's potential access to a substantial proportion of the entire NIH budget. Now, what are the challenges? Well, a lot of grant applications are submitted at NIH in response to what we call funding opportunities. And in NIH language, people call them NOFOs, notices of funding opportunity is a NOFO. And at the same time that all this is happening and we're being told that we want to focus on whole person health, we're also being told that we should have fewer funding opportunities. And funding opportunities now are becoming less easy to publish, right? If an institute wants to publish a funding opportunity, has to jump through more hoops, take a longer time. And this is a website that you can all go to if you want to find out what are the existing funding opportunities. But another important take-home message from this is that if there are fewer funding opportunities, what does that mean? It also means that there are more opportunities for what we call investigator-initiated projects. So these are projects that the person will just write. You know, if somebody wants to write a grant, this is the way it's always been. This trend towards more and more and more funding opportunities, specific funding opportunities, is relatively recent, and that's the pendulum has kind of swung in that direction quite hard, I would say, over the last 10 years, and now it's going to swing back. And this has happened many times in the NIH's history. It tends to go back and forth. There are times when there's more focus on investigator-initiated research, and other times it's more on more prescribed funding opportunity. This is now a time when the pendulum is going to swing back. So we know this already. Now, so this is, in a way, good. However, the hiccup, though, is that when you have a funding opportunity, typically it comes along with its own review group, like what we call a study section. That's the nice thing about a funding opportunity, because you submit your grant application and you know it's going to get reviewed in a group with like-minded grant applications, because that's how it's set up, right? And sometimes there's even access to a set-aside amount of money for that topic. So in a way, that's an advantage, right? To have a funding opportunity. If you want to try from the NIH perspective, you want to try to promote an area of science, you can do it that way. From the researcher's perspective, it's a way to have your grant reviewed by a group of reviewers who will kind of understand the topic, right? Well, what's going to happen now, though, is that we're going to have a big change in the peer review process, which has already started to happen. It's already now happened for the last 6 months. There are no longer any what we call special study sections that are at specific institutes. So in the past, what was happening was that you can see that the path was, you submit your application and then it gets assigned to a specific institute or center. Say the application could get assigned to NCCIH, for example, if it has something to do with a complementary therapy. And then, depending on whether NCCIH is holding a specific in-house study section or not, it can get reviewed at NCCIH, or if it isn't, then it gets reviewed as what's called a Center for Scientific Review, or CSR. And not all applications go to CSR, but a good amount go to NCCIH up until now. Then it gets reviewed, and then eventually the application gets before, and then it goes back to the institute, and there's a second level review with council, and then there's a decision about funding or not. So, just to give you a sense, in the past, you can see from 2015 to 2024, you can see on the left the percentage of applications that were reviewed by CSR and reviewed by NCCIH was about half, 50-50. About half the applications were reviewed what we call in-house. If you look on the right, the percent funded applications that were reviewed in-house is higher in the ones that were reviewed than the ones that were reviewed at CSR. So if you look at those two grants, you might conclude, oh my God, if we no longer have NCCIH study sections, what's going to happen to our funding rate? It's going to go down. Well, that would be a logical conclusion, right? So, since now we are getting rid of all, and this is not just at NCCIH, this is throughout all of NIH, right? All the applications are going to go to CSR. So, what can we do about this, right? So at CSR, what happens is that there are what they call special emphasis panels that are created when there's enough like applications that are submitted. If they got 200 applications on, say, osteoarthritis of the knee, they're going to create a special emphasis panel on that. Now, if you have an application right now, if you submit an application tomorrow on whole person health, the chances are there's not going to be 200 applications on whole person health that could justify CSR creating a study section for that. So probably what's going to happen is that application will get thrown into some random study section that might contain a whole lot of other applications that had nothing to do with whole person health. And that's kind of a tricky thing because it's not necessarily a death sentence for that application, but it's more likely that the reviewers might not have any specific particular understanding of the topic, or it's going to be more of like a hodgepodge and more of a unpredictable situation, right? So, what could we do? One way would be to clearly identify an application that it is about whole person health. How do you do that? You put whole person health in either the title of the application or the abstract. That way, when they do the triage and they decide where to put it, if they get 200 applications about whole person health, they're going to go, oh my God, we need a special emphasis panel on that. Makes sense, right? So, even though, remember at the beginning, I was talking about these three different things. We have integrative health, we have whole health, we have whole person health. My advice is that if you're submitting a grant application to NIH, you should use whole person health. Why? Because that's the term that's used at NIH right now, and that's the term that MAHA used. So use that term if you want to be bin together with other applications. You could say whole health if you want. I'm just not sure it will get picked up. So the term whole person health is probably the term that, it's not that it's a better or worse term, it's just, as far as research is concerned, it's probably the term that's more likely to lead to an assignment to a whole person health study section. So clear definitions are really, really important for research purposes. Another thing that I can suggest that people might want to do is include this whole person health diagram as a figure in the grant application. Why not? It's published. I've put it here, the URL for the article where this has been published some time ago, as well as a barcode. People are free to download that. They're free to copy it. They're free to paste it onto their application and put it in their background and significance and say, this is why my application is relevant to whole person health. That is perfectly okay. Now, you notice there's a subtle difference in this diagram to the one I showed you earlier. This particular one says psychological stress as opposed to chronic stress. This was an earlier version of this diagram, and since then we started using the word chronic stress instead of psychological stress because it was clear that some people tend to conclude that stress is only psychological, but in fact, chronic stress affects every part of the body in addition to the emotions and the mind. So it's not wrong to say psychological stress, but there's going to be hopefully a new version of this diagram that's going to be published hopefully soon. But it's not wrong to use this one. It's just that this is the one that is currently published. But if you keep an eye on publications, you'll probably see hopefully the new one. So, next question. How do you measure whole person health? It's one thing to write a grant application on whole person health. If you don't have a good way to measure it, you're going to be dead in the water. People are going to say, well, what is this? Are you going to, how are you going to know whether the whole person is getting better? My opinion is that a better way to ask this question is not to think about it in a static measurement. Is this person healthier than that person? It's looking at it on a dynamic way. Is this person healthier a year ago compared to now? Or which direction is this arrow pointing? Is it pointing over time towards health or away from health? Because everybody's health is quite unique. But within a person, you can look at and see and this is a very important thing to understand, is that this is, first of all, a very individual thing. And if we understand which direction the arrow is pointing, we can not only track the person's health over time, but also study best ways to assist the person in pointing the arrow back towards health. It's not giving a treatment like a pill that is going to fix the problem. It's helping the person improve their own health. It's a very different approach. So, what do we need? We need a concise instrument to measure the trajectory, the direction of the health trajectory, not an absolute measurement of health, okay? Whether it's towards health or away from health. And it needs to be for the whole person, not just, sometimes people talk about heart health or brain health. Your heart health is related to your brain health because it's part of you. So it's the whole person. So, I've underlined the word concise. Why? Because when we first started talking about whole person health at NIH, I used to get a lot of eyes rolling. People say, you want to boil the ocean? Or how are you going to measure all of this? You're going to need hundreds and hundreds of measurements, right? If you wanted to ask people about their own health from their own perspective, how many questions do you need to ask? If you were to take, like, for example, understand about sleep and about diet and about physical exercise, but each of these consists of 10 questions, pretty soon you've got over 100 questions. Nobody's going to fill in questionnaires that are this long, especially if you want to add a measurement of whole person health to an existing study. 5 minutes. Okay, thank you. You're going to be in trouble if your questionnaire is overly cumbersome because it's too much of a burden on participants. So we looked at existing instruments, and the instrument that was already in existence that we really looked hard on was the PROMIS 10, global scale. 10 questions, that's nice, it's concise. It did talk about some aspects of health, general health, quality of life, but there was nothing on diet, nothing on stress management, nothing on sleep. Instead, there were questions about pain, fatigue, emotional distress. You can see it's more focused on negative outcomes than positive, and there's some clear things missing. We looked everywhere. We could not find a single instrument that satisfied our criteria of being concise, focusing on positive health processes, and also to cover the major components of stress, diet, and lifestyle. So we created this instrument in collaboration with the CDC called the Whole Person Health Index that covers a lot of these domains, and some of them that also are in the PROMIS 10, but some that are not. And here are the questions, and I'm not going to go through it in detail, but you can see I put the barcode in there. All these questions have been validated by the CDC, and it's currently being deployed in the National Health Interview Survey to 40,000 households, and also it's being deployed in the All of Us initiative, which is aiming for 800,000 participants. And the nice thing about the whole person health questions is that they can be, each question is on a scale of 1 to 5, and right now, the way we're doing this, we're not weighing them in any specific way, but adding the numbers, you can get one number, which is the Whole Person Health Index, by adding all the numbers together. And you can see that if you add them up, you could have a overall integrated impact of the intervention on multiple systems. And so a healthier state would have a higher whole person health index than a less healthy state. Now, and this is just to show you where it's going to get. Now, just to show you how important this is a pretty typical study, a nice study. It was a randomized clinical trial of mindfulness for chronic pain. And the main outcome measure was pain interference. You can see that it looks like a good, separation between mindfulness and usual care. But look at the scale. The scale does not go to 0. It starts at 4.3. It goes from 4.3 to 5.7. What does that mean? It means that the differences between the groups are tiny. And so what you see is that these effect sizes are very, very small. However, they looked at a whole bunch of other things: pain intensity, physical function, fatigue, sleep, social roles, etc. All of these had statistically significant differences across all these measures, but each of the magnitude of these effects was extremely small. What does that mean? If they had had an integrated measure, if they had had a way to compile all these measurements into one measure, it may have been additive, right? It may have been larger, but nobody does this because we don't have the measure. So I'm going to skip over this, but this is a paper that looks at the economic impact of whole person health. Some of you may have already seen it, showing that really, we really need to demonstrate that a whole person approach may result in reduced healthcare spending over the lifetime, but that it needs an initial investment. You can see that the difference between the red and the blue is the red is the conventional care. You can see that healthcare expenditures goes up and up and up and up and up. And in the blue, there's an initial investment in early interventions, preventive, multi-component interventions, lifestyle, etc., which costs money initially, but over the course of the person's life, it results in healthcare savings over time. And this was a hypothetical case, but it's a very instructive one. So I'm going to just, I'm out of time, right? So I'm going to skip over this just to tell you that the whole person health index can also be very helpful for basic and mechanistic studies, looking at fundamental mechanisms of health, to understand how when you have a network of physiological changes, they can either go towards health or away from health. But how would you know unless you have a measure? So we've recently funded a very important initiative to look at a whole person, what we call the whole person physiome, to build a network map, a knowledge graph of the entire person that can be linked to clinical measures as well as to organs and anatomy and cells and molecular, to create this kind of whole person integrated physiology that will allow us to not only understand which direction the arrow is pointing using the whole person index, but also what kind of physiological measures can occur when a person is going towards health or away from health. We don't really know. Is salutogenesis the same thing as pathogenesis in reverse? Or is it an entirely new process that we need to understand? We don't know this. So what kind of research is needed? We need basic and translational research on multi-system physiological processes and mechanisms of health restoration. We need randomized clinical trials of integrative health and lifestyle interventions using whole person health as a secondary outcome measure. And we also need longitudinal cohorts tracking the whole person health over time. So I would say my message to you all is there are tremendous opportunities here. We should seize the current moment of NIH's focus on whole person health. Keep the investigator-initiated grant applications coming, no matter how difficult this is. Keep definitions and key terms consistent in grant applications. Use the whole person health in the application. Use an integrated measure, such as the whole person health index. And in my new role at the Academic Consortium for Integrative Medicine and Health, we can use that as a vehicle to communicate and better understand all the changes that are happening at NIH over the next, I would say, 6 months to a year, until the communications channels are reestablished. So I look forward to helping with doing that, and I'm happy to answer any questions.
Dr. Langevin, for visiting us and for an informative talk. There's 2 microphones if anyone has questions. We have just a couple minutes left.
Over.
That's okay. There's been well over 100 people on Zoom right now, and I printed out some of their questions. I guess I'll give you your. There we go. I guess I'll give you your choice. Do you want the politically charged one, or would you like the clinical one?
It's up to you.
Okay. Given the decimation of some federal agencies that perform research, for example, the FDA and CDC, how likely is it that high numbers of academic researchers will now pursue opportunities in the private sector, like big pharma?
Well, it's up to people what they want to do, right? I mean, I can't, I don't have a crystal ball, but there always have been opportunities in the private sector, and people should seize whatever opportunities are in front of them that fit best their needs. Say, fine, whatever people want to do.
Okay. Mari.
Hi, Dr. Langevin. I'm Dr. Ricker. We met earlier today. One thing I've been, first of all, thank you. This was incredible. One thing I've been thinking about during your talk was this sort of double standard that you mentioned around proving cost effectiveness to things that we know work, that now we're being, GLP-1s are not being held to a cost-effective standard, for example, but integrative approaches which have evidence are being held to this different standard. Could you speak to that and how we might integrate that into our future research?
Well, comparative cost effectiveness, I think that the difference is that when you give GLP-1 agonists, somebody will lose weight really fast, right? You can measure this quickly. You can show very dramatic results very fast. When you have a non-pharmacological intervention, typically the results can be slower, and it can sort of sometimes be more kind of a waxing and waning process. Sometimes people, will not adhere to the lifestyle change over time or not. It tends to be more of a long-term proposal project. So the return on the investment may, just like this Mrs. M, case story demonstrate, may take a long time to demonstrate. This may be one of the reasons why insurance companies are skittish about reimbursing treatments where the return on the investment cannot be demonstrated quickly. I think it will require a little bit of a mind shift. There are some places, like for example, a good example of that at the University of Vermont. They've recently, the hospital approved a bundled payment system program for chronic pain, without necessarily having the evidence up front that it was going to save money, but it ended up reducing emergency room visits by a substantial amount. So they didn't end up being effective, but they had to do it kind of on faith and on common sense type of argument. Not all insurance companies are going to agree to do that, and it may be that it's an exception, but the more you can have examples of that, like University of Vermont right now, Medicaid is going to pay for the program, and so you can use examples like that and replicate them in other parts. Anytime you shift a paradigm, and this is I don't use the word paradigm lightly. This is a paradigm shift. It's going to require additional steps. That's just a fact, right? So got to be just ready to do it. It's not going to be easy for sure.
Hi, my name is Ski Chilton. First of all, I want to thank you for funding my research for the last 25 years, including a recent multi-center clinical trial. So thank you. I guess my question is predictive medicine, precision medicine, utilizing things like genomics, metabolomics, lipidomics, and putting that into the model that this person-centered care, how do we translationally bring those Venn diagrams together?
Yeah, good question. Unfortunately, at the end of the talk, I had to skip a little bit on that section that came after what I talked about, the physiome. That's what that's all about. Once we can understand the body as a whole network of physiological interactions, including cellular and molecular networks. Then we can start to put the whole puzzle back together, and then we can start studying the effect of, say, a lifestyle intervention, not just on one or two molecule, but the entire network. And this is now feasible. We can do this, as you know. So, but we have to ask the right question. So there are some programs that are currently underway. One of them funded by the NIH Common Fund that is starting to look at that, where to really do a deep sort of phenotyping of an individual and see if you can identify signatures of health restoration. There's going to need obviously a lot more programs like that, but I think there's no reason why we can't do this. I think that it's certainly within the horizon. Yeah.
People often talk, Helene, about how difficult it is to turn an ocean liner, to turn a ship. You've done an amazing job in achieving this, and it's just remarkable how you've gotten this concept in so many directions in so many areas. And I suspect part of how you accomplished this came in the earlier days when you were wearing a different hat, when you were defining the fascia as a whole body network and seeing how we need to stop thinking of different areas being separated at the physical level and bringing them all together. So I would love it if you could just give us a brief overview of how you see the fascia as the whole body network in a similar way that you want. It's such an important part of the whole person.
Yeah, thank you, Richard. I love that question. So, you know, in that little diagram that I showed about the sort of tower, with all the different levels and all the different organs, we now have a fascial system that is its own system that connects all the other systems. So just like there are some other systems like that, the immune system, for example, the immune system is all over the body, connects the whole body. The endocrine system also connects the whole body. The fascial system is another such system. The problem is, up until recently, we didn't even talk about it because the fascia was a part of the body that was totally ignored. But I'm glad to say that under the leadership of Dr. Carla Stecco, there is now a sort of a paper that was published recently proposing a fascial system that was now hopefully going to be incorporated into the Terminologica Anatomica, as well as into this whole person physiome, and we're going to make sure of that the fascia is incorporated into the whole person physiology. So it's going to be a great way to finally beginning to understand the role that fascia plays in health as well as disease. But I think that it's a very, very exciting development that we're going to be able to put back into the puzzle. So thank you for the question.
I think that's a great note to end on, and I couldn't agree more. I want to thank everyone for showing up here in person, everyone that came online. I want to thank our awesome team behind the scenes putting this together, and a lot of hard work. Provost Prelock for being here, and let's give one last round of applause for the pioneer and amazing work. Thank you all.